Right, so I'm already breaking a rule, which was to deviate from the language of seek, keep and treat. So reach, engage, support. I was asked by Dave to sort of really talk to the evidence as to how we've arrived at this approach, and that's what I'm going to do. But I could have equally called this talk Reading the Shadows, because as you start to shine a light on that evidence base, you realise it's not clearly illuminated, and sometimes it casts one or even more shadows, and so we have to read those shadows. So just bear that in mind as I sort of go through this talk. Things aren't always black and white. So I'm going to start right at the beginning. This is looking at all-cause mortality in Scotland compared to Western European countries over time, way back to the 1950s. And you can see that it wasn't great. It was at the sort of upper end of European mortality rates. But then around about 1980, something starts to happen, and our progress slows down. And up until about 1980, the majority of mortality was due to chronic disease, such as cardiovascular disease, cancer, and so on. And that flipped around about the 1980s to external causes, such as alcohol, drugs, violence, and suicide. And around this time, at the beginning of the 90s, there were epidemic shockwaves taking off. And that first epidemic shockwave was of suicide, and that peaked in around about the year 2000, and predominantly in young men from deprived backgrounds. Next, at the same time, an alcohol epidemic wave took off. I'm sure we've had a lot of coverage of alcohol harm in recent times, and we'll be having minimum unit price being introduced in Scotland as one response to that. And that epidemic wave peaked around the years 2003, 2005, have come down and is flattening off. And also in the late 80s, early 90s, the third epidemic shock wave took off, was for drug-related mortality. And as we know, that epidemic shock wave has not peaked as yet. And here we are all familiar with these really sort of upsetting statistics. So black line is number of drug-related deaths over time. And last year, 2016, 867 drug-related deaths in Scotland, the largest number ever recorded. The blue line here shows the number of deaths in those 35 and over. And you can see that that curve, the shape of that upward trend, is really being driven by the numbers in that age group. Now, the majority of deaths were due to heroin and or morphine, and men higher rates than women, although women's rates have been increasing at a relatively faster rate. And over half of those who died of drug-related deaths, certainly in 2015, lived in the most deprived quintile. Now, setting those deaths in context, this is a figure taken from the Scottish Burden of Disease study that was published recently. Drug use disorders is the sixth leading cause of early death in Scotland. Years of life lost, 26,000 in 2015. So that really puts it into quite a context. So, well, why are drug deaths in Scotland going up? Is it purely a function of drug use going up? So if we look at self-report drug use from surveys, population surveys, this is from the Scottish Crime and Justice Survey, well, over time, self-reported drug use is actually falling. And the majority of that self-reported drug use is actually for cannabis and other drugs. It's not for opiates. And if we look at England and Wales, just bearing that in mind when a little later on we'll be comparing Scotland with England and Wales, drug use, similar sort of figures, not really going up at all. And a similar pattern if we look at children, boys and girls aged 13 and 15 over time. Self-reported drug use, and the majority of this is for cannabis as well, is been falling over time. Okay, but we know that these population surveys don't pick up hidden populations or populations that aren't in these household surveys, as they're called. So for young people, that might be children looked after children, children in care. For others, it might be the more marginalised hidden populations, such as the homeless and so on. So in Scotland, we've made efforts to try and estimate those hidden populations. Many of you be familiar with what's called the drug prevalence studies. They started in Scotland in the year 2000. And so we estimate, it's not an actual count, we estimate the number of what we call problematic drug use, and that's opiate and or benzodiazepines. And if we look at that, there actually has been a slight increase over time since the year 2000 in the problematic drug use scale. The most recent year, 12-13, 61,500 people aged 15 to 64 using opiates and or benzodiazepines. And there's a new prevalence study coming out shortly from ISD. So is it just a function of that then? When we look, remember I said I was going to compare to England and Wales. On your left-hand side, there's drug use deaths, and if you focus on the opioid deaths, that's really kind of what most of our drug use deaths are from, you can see that Scotland, in the blue bar, the rates per general population is over double that of England and Wales. So you might think, well, is that because we've got more people that are having problematic drug use? Well, the right-hand side of this graph, if you look at the opioid deaths, show that even when you account for the greater number of, or the relatively greater number of people with problematic drug use, we've still got a higher rate in Scotland. So there's something else going on. And that could be increased risk. So are people in Scotland exposed to greater risk from a drug-related death? Now, we have quite a body of evidence. We know what these risk factors are. From the top, we've got injecting drug use, higher risk of death from overdose, and also prevalence of bloodborne virus infection and so on. At points of transition, when you're leaving prison, there's evidence to show higher risk of drug-related death, and also in hospital. We know that it's linked with deprivation. We know that multiple drug use, many of the drug-related deaths in Scotland have got more than one drug on board, so polydrug use and other risky behaviours such as alcohol and so on. Frequent entrance and exit from treatment. We know that there are risk points at the beginning of treatment and also just coming out of treatment, but also multiple in and out. We know that older age is a risk factor, and John Budd will be talking in more depth looking at older drug users later on. And also being male is associated with a greater risk of drug-related death. So we then look at, we've got something called the Drug-Related Death Database here in Scotland from 2009. For every drug-related death, there's a large collection of information on each death, comes in, is collected at local level, comes into us at ISD, where we publish the National Drug-Related Death Database report. And from that database, this is the latest year that we reported on in 2015, it's evident that these risk factors are there. So predominantly male, increasing age, opiates implicated in the majority of them, many long-term drug use, previous injecting history, over half living alone. That's not so much a recognised risk factor in the literature, but certainly something we're picking up. Many had comorbidity, that's a medical condition, psychiatric condition, and all the prescribing that would go along with that. Polydrug use common, and many people had multiple overdoses. But then there's maybe something else going on in Scotland. Have we got some sort of additional vulnerability? In other words, worse outcomes for the same exposure? Now, I would absolutely commend, if you've not already, read this report by David Walsh and colleagues from the Glasgow Centre of Population Studies and others. They've been trying to dig down into the Scottish effect, which you strip it away is the Glasgow effect. So they're looking at all-cause mortality, but also drug mortality. We do have higher levels of deprivation in Scotland, but that doesn't explain all the difference in mortality. In fact, by 2011, it only explained a third of the difference between Scotland and England and Wales. And then remember back at the beginning, I said these epidemic waves started kicking off in the early 90s. So what was going on in Scotland in the 80s that might have caused that? Well, we all know that there was a massive deindustrialisation going on throughout the whole of the UK at that point in time. There were mining industry, closure of mines, of steelworks, the shipbuilding and so on. So here was a whole generation, and when we look back at the statistics, we actually can see it's a cohort effect. Those born between 1960 and 1980, predominantly young men from deprived backgrounds, they're the ones that were dying. And continue to. So the colleagues looked at other cities like Liverpool and Manchester that had also been going through that deindustrialisation, but still there was something going on in Glasgow over and above that. So they went back in time and they had a look at some of the regional and local planning decisions that particularly affected Glasgow. So for example, moving people out to the new towns, building high-rises away out in the periphery. And in other words, that deindustrialisation, that shock came on top of previous shocks. So maybe there was something going on in the Glasgow population that they were more vulnerable to that shock, less resilient. And there's also some emerging evidence that even at the biological level, there's more susceptibility. So for example, colleagues have just published in The Lancet with hard evidence that for a given level of consumption, those from more deprived backgrounds experience more harm. So I think it's a really fascinating but important part of the story. So having looked at background, the risk factors, well, what can we do? What works to prevent drug-related deaths? Well, we do have a body of evidence, and that was recently summarised by my colleague Aileen Dickey, who's in the audience here at the front from Health Scotland. We know that being on opiate substitution therapy is protective against the risk of death. But we also know that there should be support to overcome barriers to access services, as well as stay in treatment, echoing what Dave was saying earlier on. And that treatment needs to be individually tailored with wider needs identified and addressed. So what have we been doing in Scotland in response to this epidemic that we've been experiencing? Well, quite a lot. This is not by any means exhaustive, but right from the go-get, Scotland was out there doing needle exchange in the 80s against the sort of prevailing wisdom. There was a lot of resistance around that. Big drive to get people into treatment. The now defunct Scottish Advisory Committee on Drug Misuse did a big review on methadone, and then the Essential Care Report, if you can remember that was calling for those wider support needs to be addressed. And that fed into the National Strategy Road to Recovery. We had reform of commissioning alcohol and drug partnerships in 2009. I mentioned drug-related death database. And then 2011, a drug treatment waiting times target was set. A national naloxone program got off the ground. We had to go back in 2013. There was a big ORT review, and really that was just to kind of keep re-establishing that methadone was a core plank of treatment. Not the only one, but a core plank. And we've had in 2011 and 2014 the NHS taking over healthcare in prison and then in police custody, and that's work I've been involved with, so we've developed good practice guidance there. And then more recently, as Dave mentioned, SDF have produced a couple of reports, Staying Alive and the Older Drug User Report. So lots of action, lots of good evidence-based activity. So for example, take home naloxone. since 2011, nearly 40,000 take-home naloxone kits have been issued. And if you look at that as in relation to those at risk, so roughly 3 out of 10 take-home naloxone kits issued to those at risk over time. I mean, in 2014-15, over 4 million needles and syringes, that's 71 per person at risk. So a lot of activity going on. And then if we start to look at these elements of getting into treatment, this is from the Scottish Drug Misuse Database. This is the number of new clients assessed for treatment over time. Now, that's roughly been bobbing along between 11 and 12,000 per annum. And those are people, they're not new to treatment. They're new to treatment they've not been in treatment within the last 6 months. So there is a possibility of people going in and out there. But we know that we've got issues with the data quality of Scottish Drug Misuse Database. It's about 70% complete. And it actually doesn't tell us what treatment people go on to. So then this graph is showing us the top line is data from the drug and alcohol waiting times database. So that's telling us here, that's the number of completed waits. Now that is not at an individual level, as the previous slide was. It's the number of completed waits. And so one person in a given year could have multiple treatment episodes in and out of treatment. And also, it's possible that they could have multiple waits for just one episode of care, particularly if they're transferred from one service to another. Now, neither of, and that SDMD, that's along the bottom, that's the number of initial assessments, not the number of individuals, so the numbers are slightly different from the previous slide. It's a number of initial assessments, but you can see the gap there between the two systems. But that doesn't tell us how many people are in treatment. So remember I mentioned the prevalence study, so as well as estimating the number of people that with risk of, with problematic drug use, it also counts the number of people in treatment for that given year. So 2009-10, using those two figures, that would suggest that about 42% of those in need were in treatment. But by the next prevalence study in 2012-13, that had fallen to 35%, if this is to be believed. We're looking at shadows here. But remember that number, 21,314. That's the number that they measured in treatment. Just hold that thought. And that would compare with a percentage in treatment in England and Wales of about 60%. So this is really some evidence to say, are we doing well enough in terms of getting those that need to be in treatment into treatment? But just be cautious about direct comparisons between England and Wales. There's sort of definitional issues there. And then just some further evidence from drug-related death database. So a third of those who died in 2014 had never been in contact with specialist drug treatment. So there's people out there really not coming in contact with services. Now, moving on, the Drug and Alcohol Waiting Times database does measure or does collect data on the type of treatment. And we know that the target, 90% of those waiting should wait 3 weeks or less. And figures for 16 to 17, that target was met. It was 94% nationally. But waiting for what? So the waiting times data, treatment being received, is measured when the clock is stopped for waiting times. And so for the majority, this is showing up as the treatment they're receiving is structured interventions. So for 9 out of 10 people, we don't know how long people were waiting for the more effective interventions. Not saying everyone is going on to ORT, but we don't know. So this is one of the difficulties with this system, is we don't exactly know how long people are waiting to get on to treatment such as opiate substitution therapy. But let's shine the light from another angle. This this is a graph showing the number of people, now it's estimated number of people on methadone. And this is taken from prescribing data. Prescribing data, we've got something called an individual identifier number called the CHI number. Because not all scripts have got CHI number, we have to be cautious about this, but ISD now estimates the number of people on methadone. So in 2016-17 at the far end, there were over 26,000 people estimated to be on methadone, and that is said to be a minimum, so the number could be higher. Now, remembering that figure back from the previous slide of 21,314 as being in treatment, which gave us the 35%. Well, for 12-13, the figure from this is 25,000, so a higher number in treatment. And so why might that be? Well, that's probably because many of these scripts are from general practice. So it's kind of definition of, well, what do you mean in treatment? You're actually receiving specialist drug treatment, but you're receiving it from a GP and not from a sort of specialist drug treatment service. So if we then applied that thinking to the latest year, 2016-17, that would actually give us 42% in treatment, and that's the minimum. So numbers might be even higher. So a little bit brighter than perhaps we thought. So once in treatment, what do we know about whether people are getting optimal prescribing? Well, from drug-related death database report, 29% were actually on ORT at the time of their death, which speaks a little bit to, well, are they topping up? Are they they're needing something else perhaps? 26% were on methadone, and we were able to actually look at the dosage of that. And of those, 39% were on below the recommended dose. So there is something going on there that we have to make sure that we know whether people are on the right dose and maintained on that. Then what about leaving treatment? So from Scottish Drug Misuse Database, we can look at discharge type. And bearing in mind Scottish Drug Misuse Database, element of under-recording, but I think if we look at the latest year here, we've got nearly 13,000 discharge episodes. So these are not individuals anymore. An individual may have more than one discharge in a given year. But I think the main message for me here is that over a third, 38%, had what I'd call a non-positive discharge, so disciplinary or unplanned. So that's over a third of people, treatment episodes, being left with a non-positive outcome. Continuity of care, a risk factor, as we mentioned. So from drug-related death database again, 3% of those who died of drug-related death had been released from prison in the 4 weeks prior to death, and 7% had been in police custody. These are at-risk times. And then taking a look, this slide is showing hospital admissions for drug-related death. Now, we know that the risk of a drug-related death is about twice that on release from hospital. 10% of those who died of drug-related death in Scotland had been discharged from hospital in the previous month. Now, what we're also seeing on this slide, the top line is what we call number of stays or old-fashioned discharges. Middle line is the number of individuals in a given year. And that bottom green line is the number of new individuals that have never been in hospital before with a drug-related hospital admission. And I should say that the majority of these, over 60% of these admissions, are due to opioids. And we can see that over time, certainly recently, those lines are all rising. I think John will probably be speaking a bit about hospital use and hospital admissions in his talk. But also what's happening is that the gaps between are kind of widening as well. And that represents churn. So for each new patient, the sort of revolving door phenomenon is happening. So that speaks to me anyway that we're maybe not using the opportunities in that hospital setting to make sure that people get engaged into treatment and stay with treatment. And then what about the evidence of wider support? back to Eleanor's report here, there is a clear evidence base around a broad holistic approach designed and tailored to the health and social care needs of individuals is going to improve the effectiveness of interventions, help increase motivation and prevent dropout. And if we look at drug-related death database again, just over half who died had not been in contact with those wider support services. So they've not been in contact with non-treatment drug services. So missed opportunity there, I would say. But these wider support services, as we all know, are under pressure. This is a quote and they're under pressure from things like welfare reform, austerity. And this quote, which I'm not going to read out, speaks for itself, is taken from further analysis of the older drug user report. And there will be a report coming out from the Scottish Government, and this is looking at drug-related death, particularly in women. Let me read that. So just to think about going forward from where we are now, what do we do? Do we do more of the same? Do we do more of getting people into treatment and delivering treatment? Do we do the same things but do them differently? So do we redefine and redesign drug treatment services, or do we do different things? Or do we do a mixture of all three? And this is my second last slide. This is a list of possible things that can be done. So we need to improve detection, access, retention and treatment. We certainly need to adapt to the profile of older drug users. Services, perhaps doing them differently. Outreach, low threshold, fast-track re-entry for those that drop out of treatment. Austin's spoken about this, a duty of care. So if someone doesn't come back into treatment, or is there not a duty of care of service providers to sort of check up and find out where they are? There's been a lot on trauma recently, particularly with women. So trauma-informed services, really important, and services that and wider, that there should be no stigma to all this. Doing things, the same things, but doing them differently. We've got in Glasgow the sort of plan for an injecting room and heroin-assisted treatment. We really need to understand our prescribing better. So not just what doses are people on in methadone, but also I would argue prescribing for comorbidities. So a lot, antidepressants. We've got chronic pain, the gabapentinoids, and so on. If you're mixing that in, you've got to really think carefully about what that might be doing. We've not monitored non-fatal overdoses. Now, I know that some local areas have been working with the Scottish Ambulance Service to do just that, and they're doing that down in Wales, because those are sort of signals of someone at risk. Wider support, we'll be hearing later on about some of these wider support services this afternoon. Really important at those transition points to ensure continuity of care. And I think recognising that harm reduction is part of the recovery journey. It's not a black or white thing, harm reduction versus recovery. It's part of that recovery journey. Something dear to my heart is optimising delivery in the justice settings, but also better detection and referral and generic services. So should we be putting in drug liaison services into general hospitals, for example? We've got a new information system called DAISY coming down the track, which is for drug and alcohol specialist treatment services that will be producing follow-up data. So they're going to be plugging some of the gaps that we've been talking about. We've got a new research network that's been set up, for Drug Research Network Scotland. An evaluation, really important. So all that list of things that I put up earlier of what we've been doing in Scotland, we never had a formal evaluation of national strategy. So we didn't really know whether it had made a difference or not. And it's possible that it actually did make a big difference, but we just don't know. There could have been far more deaths from drugs in Scotland if we hadn't put all those things in place. But we need to try and nail that. And just lastly, optimise the legislative and regulatory framework. And I just want to, also really important to tackle upstream, prevention, tackle income problems, housing, social cohesion, adverse childhood experiences, make sure we've got healthy environments, and talking about this earlier on, more local democracy. Because if we don't tackle these upstream things, we're risking another epidemic wave, because the conditions are not, dissimilar at times to what was going on in the 80s. And some last words. These are from a young man who was in Pullman, young offenders, with drug problems, and he was picked up by Moving On Action for Children, which was a programme. Worked with them, went on to become a volunteer with them, and then some years later was interviewed by a colleague, and that was what he said. He was just about to set off travelling the world. And the final word: most drug deaths are preventable. Thank you very much.